Good afternoon. So today's lecture topic is head injury. So starting off with this is the basic anatomy. I think we all have covered this in your anatomy lectures before. So we will look at scalp and meninges. So scalp, as the name implies, it's like a mnemonic for what it stands for. So skin, connective tissue, aponeurosis, loose aerial tissue, followed by the peritoneum. So there's a few concepts in anatomy, and we will also look at a few concepts in physiology. So as you look at the skull itself, it's lined up by intracerebral arteries, and there's also arteries outside uh, the skull layer. And in between both these arteries, there are bridging veins. So all these structures, when an head injury occurs, are at risk of damage. Whether the damage occurs intracerebrally or outside. When there's a skull fracture, it damages the middle meningeal artery. So look at a few concepts in physiology as well. We'll look at what is Monro-Kelly doctrine, look at Cushing's reflex, plus the formula of CPP, which equals to MAP minus ICP. So CPP stands for cerebral perfusion pressure, which actually equals to mean arterial pressure minus the intracranial pressure. So what does Monro-Kelly doctrine say? So this doctrine actually it actually states that the skull is a fixed container. So skull is divided 10% CSF, 10% blood volume, and the remaining is 80% brain parenchyma. And all this exists in equilibrium, meaning it's all equal. And if there is one component goes up, which means another component has to come down to compensate. Which actually brings us to cerebral perfusion pressure, which equals to MAP minus ICP. Okay, so what usually happens in a traumatic brain injury is when there is a trauma, there is injury to the vessels in the brain, the blood volume in the brain increases. When this increases, and there is no reduction in brain parenchyma or there is no reduction in CSF, that's when you have increased intracranial pressure. When the increased intracranial pressure, the pressure goes up. If you look at the formula, cerebral perfusion pressure equals to MAP minus ICP. So when the ICP goes up, then the cerebral perfusion pressure goes down, meaning blood supply to your brain gets cut off. So that is where the head secondary insults happen after brain injury. So as the molecular doctrine says, the everything has to be in equilibrium. Because skull is a fixed container. So a few things that happens once the pressure goes up, patient ends up having hypertension, and there is also bradycardia. So hypertension is SNS mediated, and when there is medullary ischemia, it is translated as bradycardia, which with diminished breathing effort. So this is Cushing's reflex. So remember this Cushing's reflex, it can come up in an MCQ. As for Monro-Kelly doctrine, I can ask this in SCQ. So have to describe what is Monro-Kelly doctrine and also the formula of CPP equals to MAP minus IC. Okay, so what happens in a traumatic brain injury? So when there is trauma, it may or may not resolve with a soft tissue injury, skull fracture, or a TBI. So this can actually from a blunt injury, penetrative injury, or even a blast injury. So there is structural or physiological disruption of the brain resulting from a brain injury. So primary brain injury, there is the one that occurs at the time of injury. Let's say patient is a motorbike rider, falls down, not wearing helmet, head hits the pavement or a stone. So that is the primary brain injury which occurs. So secondary brain injury is indirect injury, meaning whatever physiological change that happens from the primary brain injury following the acute insult, if it's left untreated, then the secondary brain insults occur. So like you hear the mentioned, intubation, drugs causing hypotension, and difficulty in intubating the patient, all this can actually result in secondary brain injury. So most of the time in our clinical practice, when we see a patient, they've come with traumatic head injury. Most of the time, whatever happened in the primary brain injury, there is not much you can do. But whatever our attempts are is actually to prevent further secondary brain injury or a worsening of the primary brain injury. So one way we classify traumatic brain injury is using Glasgow Coma Scale. Have you all heard about this Glasgow Coma Scale before in any other lectures or in medical lectures?
No, doctor.
Okay, we will look into the Glasgow Coma Scale after this. So Glasgow Coma Scale, we will look into this after. It's a score where we assign whether patient how conscious or how comatose the patient is. The score ranges from 15. The lowest score actually you can get is 3. So score of 13 to 5, 15 indicates mild brain injury. From 9 to 12 indicates moderate brain injury, and severe score is 8 and below. So for brain injury itself, for primary brain injury itself, it is divided into all these types of injuries. So there's a few where you have intracranial hemorrhage. Intracranial hemorrhage can be either epidural, subdural, subarachnoid, or intracerebral. Then we have contusions where there is focal area of brain injury. So it can result as a bruise or a necrosis. Then we have something called countercoup injury. Coup meaning the side of the impact gets injury, and countercoup the opposite side of the impact gets injury. Other injuries that we get is intracerebral hemorrhage and parenchymal lacerations. Then there's another subset of brain injury called diffuse brain injury, meaning there is cerebral edema, diffuse axonal injury. So the axons in the brain can be disrupted, or patient can have cerebral edema, meaning brain is swollen up after an injury. So how do we assess these patients when they come to us regarding the conscious level? Is through a coma scale chart. This has been used for a very long time. So it's called Glasgow's coma scale. So basically, it looks at patients' eye opening, verbal response, as well as motor response. So there's a score of 4 for eye opening, there's a score of 5, and there's a score of 6 for motor. If you look at the lower score, it's no response is 1 for all, meaning the lowest score you can get is actually 3. The highest score is 50. Any patients who come in 8 or below, meaning they're actually comatose. So how do we assess? So when we see these patients, we will try to see whether they are spontaneously opening their eye, or do we need to arouse them by speech, to pain, or to response. That is for eye opening. Verbal, whether they are orientated to the time, place, and person, or they confused, or they're not making any sound or any no response. Same applies for motor. All this is assessed clinically by the bedside. So other things that we check is vital signs, pupils, and check whether there's any focal neurological deficits. And the head itself, we check for any external signs of head injury. So I think you have gone through ABCD before. So the same thing applies in assessing patients with head injury. It follows through a primary survey of an ABCDE. So in A part of the primary survey, we actually check the airways, we perform cervical spine immobilization, and consider intubation. So any patients with GCS of less than 8, we will intubate the patient. Next comes breathing. So patient to provide patient with oxygenation and to maintain the saturation levels and also the oxygenation levels. In circulation part, we will maintain the patient's blood pressure, and if there's any sources of bleed, we'll try to stop the bleeding. So D, we will check patient's neurological deficit, meaning we'll check people's check focal sign of neurological deficit, and other causes that can cause can reversible causes of low GCS, such as hypoglycemia, opioid toxicity, and alcohol intoxication. So some patient might come to you post trauma, and when you're seeing them for the first time in ED, you're not sure whether this is head injury or patient just is just drunk, overdose of alcohol, and you cannot make sure. So all that has to be corrected before we conclude that this could be a potential head injury. Then we also check the other parts of the abdomen and organ. So we check the whole body basically. So expose and check. So Commonly, when patient comes to trauma, it does not necessarily mean only head injury. They can have trauma anywhere in the body. So we'll check their face, arms, limbs, long bone fractures, and so forth. So how do we? So any patients with less than GCS, 8, it's a suspected severe TB injury. They get a CT scan regardless. So there's something called a Canadian CT rules that we follow. So those with minor head injury, when we are still deciding do they really need CT scan, these are the scores that we look at. So high risk for needing operation, anyone with a depressed skull fracture, any patients who are vomiting, any patients with low GCS. So these patients will definitely go for CT scan. So medium risk is those who had amnesia. So after an injury, fall down from moving back, suddenly they cannot remember what happened, but otherwise they are well. So we will actually consider doing CT scan for them, but it's actually a medium risk for brain injury. Most of the time we will observe. If there's any drop in GCS, then we will get a CT scan. Or if the center that you are practicing has CT facilities, probably won't want to get a CT scan immediately. So signs of basal skull fracture. These are the few signs that you have to look for: raccoon's eyes, battle sign, and also cerebral spinal split coming out from the nose or the ears, which is called otorrhea or rhinoria. So this picture here, the picture of the eyes, this is called raccoon's eyes. This is how an eye of a raccoon looks like. So those with basal skull fracture, they can have blood collecting behind in the eyes, blood collecting behind the ears. This is called battle sign, and also they can have cerebral spinal fluid leaking out through their nose, or which is called rhinorrhea, and through their ears, otorrhea. So these three signs is important. Have to remember this. This is called. These are all signs of basal skull fracture. Okay, so how do we manage patients with traumatic brain injury? So all this depends on the severity of the head injury, whether it's mild, moderate, severe. And next is whether the CT shows a surgical lesion versus a non-surgical lesion. So there's options of monitoring patients' DCS, and there's options of going in for a surgery to take out the clot if there's a blood clot. And there's also options of inserting a catheter to monitor the patient's blood pressure, followed by ventilation and sedation. This is called cerebral protection. So cerebral protect is to actually protect the patient's brain from further injury. The one that I mentioned is now secondary brain insults. So algorithm. So any severe traumatic brain injury, when patient comes with GCS of 8 or less, they straight away go for a CT scan. After which we will evaluate whether it's a surgical lesion or non-surgical. Surgical lesion meaning there's blood clot in the brain and the blood clot needs to be removed. Why the blood clot needs to be removed? Like I mentioned just now, Monroe-Cayley doctrine, extra blood in the brain. There's extra blood volume in the brain from the bleeding. The brain is a fixed container. It will start compressing the major structures. So one of the component has to come down. What happens? The brain pressure goes up. So we either evacuate the blood clot, and then we can actually put a monitor to something called an ICP monitor to monitor the pressure of the brain. Eventually, these patients will go to ICU for monitoring and cerebral protection. If it's a non-surgical lesion, let's say there's no bleeding, we will still put a catheter in to monitor the ICP and monitor them in the ICU. So severe injury, severe surgical interventions, following which there's medical management. So monitoring, so we monitor the ICP, we monitor the cerebral perfusion pressure. So the few treatment recommendations here. So if they need a craniotomy, yes, we will do one. Otherwise, we will do other ventilation strategies, anesthesia, sedatives, and also steroids. So next we'll look at a few different types of bleeding in the brain. So one of the types of bleeding that we get is called extradural hematoma. So brain has a few layers, uh, dura, arachnoid, and pia. So do extradural means above the dura. So bleeding occurs above or outside the dura. So when you look at the picture, the above picture, when the skull fractures, there is a artery which runs just behind the skull. So these arteries are at risk of fracture. So when this fractures, there is bleeding behind the skull, and this compresses on the brain. So this is called an extradural hematoma. So surgical management actually will be almost similar for all the brain bleeds that I'm going to mention. So extradural hematoma is an emergency. If the size is more than 30, they go in for a craniectomy. So this is how it looks like intraoperatively, opening up the skull and finding blood in the skull. So this blood clot will be evacuated, and then if it's done fast enough, patient will have a full neurological recovery. Next is subdural hematoma. So this bleeding occurs between the bridging veins. The bridging veins are torn, and there is blood collected below the dura mater. So it's between the dura and the arachnoid. So the three layers that I mentioned is now dura, arachnoid, pia. So below the dura, above the arachnoid, you get a subdural hematoma. So the shape difference can be seen. One, it has a lentiform shape from this picture, and the one here has a crescent shape, which looks like a half of like a part of a moon. So management is also same. No need to remember the thickness and all that. So if the GCS is poor and the subdural hematoma is big enough, they will go for surgical evacuation as well, clot evacuation. Also put up pictures for that. This is how it looks like intraoperatively. The first picture that you see on your left, this is the dura mater after the skull has been removed. Once they open up the dura, the blood clot is below the dura. So next we have subarachnoid bleed. So this happens below the arachnoid level. This is where your blood-brain vessels, intracerebral vessels, can get bleeding, and the blood actually collects in between the brain. So this is called a subarachnoid bleed. You also get intraparenchymal bleed. The brain parenchyma itself can be injured following a accident, so they will get intraparenchymal bleed as well. So subarachnoid bleed and intraparenchymal bleed, if the lesion is big enough, GCS is poor, same thing, patient goes in for a surgery to evacuate the clot. So just now we touched upon fracture of the skull. So depressed skull fractures, usually if it's compressing the brain, they will go in for surgery to remove the skull and replace the skull back. So base of skull fractures, there's three parts to the base of skull, whether it's anterior, middle, or posterior. Not very important. Just remember the three signs that I mentioned just now: raccoon's eyes, otorrhea rhinorea, and also battle sign. The other type of injury that I mentioned, injuries to the axon in the brain rather than the brain parenchyma itself. This is a bit more difficult to diagnose from CT scan. Usually, patient comes with poor GCS, CT, not much supporting features from the CT. They will need an MRI to diagnose. So this subset of patients, it's not a surgical lesion. Usually, they do not get surgeries. It's more of a secondary protection to the brain, cerebral protection. So part of the cerebral protection, head up positioning, sedation with neuromuscular block. So all this is to reduce the blood flow to the brain. So to reduce the cerebral perfusion. So sorry, to reduce the intracranial pressure and maintain the cerebral perfusion pressure. And any injuries to the brain, there is potential of getting seizure activities. So we have to treat them with anti-epileptics and also manage the ventilation. So any we will try to keep them as no more capping as possible. Then also to control the blood pressure, temperature control, avoid electrolyte imbalance and hypoglycemia. So a few other therapies that we can use: prophylactic hypothermia and also hypoosmolar therapy. So all this is to actually reduce the intracranial pressure. So reduce the temperature is to reduce intracranial pressure. Same as applies for hypoosmolar therapy. We give hypertonic saline and menthol. So this actually pulls out water from the brain so that we can reduce the intracranial pressure. So two agents that we use to as a hypoosmolar therapy: hypertonic saline and menthol. Okay, so remember these two agents uh, for MCQs. I will not ask how they work or what's their dosage. Just remember these two names. So the other operation that we can actually do is to remove the cerebral CSF fluid or cerebral spinal fluid, procedure called an EVD. This is also to manage brain insults. So ventilation therapies will maintain normal ventilation with normocapnia. Normocapnia meaning normal carbon dioxide levels. So as you look at the cerebral blood flow, the brain's metabolic demand, when there is low PaSO2, when there's low PaCO2, which means hypocapnia, or high PaCO2, which is hypercapnia, there will be cerebral ischemia or increase in intracranial pressure. So we don't want either one to happen. We don't want low PCO2, we don't want high PCO2. It has to be in normal range. So if it's low, there will be not enough blood flow to the brain, there will also be cerebral ischemia. When there's high, there will be more blood flow to the brain. It increases intracranial pressure. So that is not good as well. So other medications that we use, so most of these patients are intubated, they are sedated with propofol. They also even use barbiturates to control intracranial pressure. So steroids, no real benefit has been seen. So some centers use it, but it's usually not recommended to reduce intracranial pressure. So the another point that we look at is nutrition. So should we feed these patients? So we also actually there's evidence to show that feeding is indicated, especially if there are prolonged coma, sustained coma in these patients. So other things that we look at is infection prophylaxis and invasive monitoring, and deep vein thrombosis prophylaxis and seizure prophylaxis. The last one is Cushing's ulcers. So those with brain injury, they are bound to have increase in intracranial pressure. So this actually stimulates the vagus nerve to increase gastric secretion. So they also can end up with gastric or peptic ulcers. So these are called Cushing ulcers. Okay, so this is a very difficult topic. So I will just highlight what is very important take-home points for your MCQ and SCQ. I'll just scroll back to the top. So the layers of scalp, hopefully you all can remember. So scalp itself, it's a mnemonic. So you can look at the mnemonic. So SCALP all stands for a letter. Skin, connective tissue, epidermis, loose areolar tissue, and peritoneum. Hopefully you can remember this. This is important. And from the concepts of anatomy, so skull, behind the skull, there is a meningeal artery, and after which comes the dura, arachnoid, and pia mater. So between the dura and arachnoid, there are bridging veins. So these bridging veins cross from outside the skull into the pia mater. So these bridging veins can be destroyed as well. Below the below the arachnoid mater is where you find your intracerebral arteries. So concepts in physiology, I've mentioned, Monroe Kelly doctrine is very important. Probably you'll get an essay question trying asking you to describe what is Monroe Kelly doctrine. So if you can remember intracranial volume, CSF 10%, brain volume 10%, brain parenchyma 80% is good. But if you can tell me that these three structures has to be in equilibrium, uh, if one goes up, one has to come down, that is good enough. This formula, cerebral perfusion pressure, which equals to MAP minus ICP is very important as well. Cerebral perfusion pressure meaning how much blood goes to the brain, the pressure of blood going to the brain. So anytime the ICP goes up, if your blood pressure doesn't catch up, your cerebral perfusion pressure drops. So that is why it's very important to maintain the ICP. So another thing for MCQ, this is called Cushing's reflex. So anytime there's increased ICP, patient has hypertension, and patient also gets bradycardia. So remember this increased Cushing reflex diagram. So another thing that we commonly ask in SAQ is the Glasgow Coma Scale. What is the definition for mild, moderate, and severe TBI? The different types of bleed, which can be also questioned, and Glasgow Coma Scale. Anyone got any questions about Glasgow Coma Scale? Any queries? So this is a clinical chart. Huh? This is we do it bedside. We will assess the patient's consciousness using this chart. So management of these head injury patients same follows the ABCD protocol as I've mentioned in the previous resuscitation slides. Airway, breathing, circulation, disability, and exposure. Canadian city head rule not so important for you guys. No need to remember this. And these three signs of basal skull fracture that I mentioned: raccoon's eyes, battle sign, and then otorrhea plus rhinorrhea. So otorrhea and rhinorrhea is leaking of CSF, either from the nose or from the nostrils or from the ears. So I have to remember these three signs of basal skull fracture.
Doctor, can you
Yes,
repeat that? The
the three signs
signs.
of basal skull fracture. This one, the eyes, it's raccoon's eyes. So looks like an eye of raccoon. So blood collects below the conjunctiva. Then we have battle sign, which is blood collected behind the tympanic membrane or hemotympanium. This is one of it. And the last one is CSF leaking out from the ears or nostrils. That is known as otorrhea or rhinorrhea. So all this happens when there is fracture of the base of the skull. So either blood seeps into these areas or CSF leaks out through the nose or through the ears. So these are signs of base of skull fracture. Management not so important. I wouldn't question much because I don't think you all will be managing any head injury patients. No need to know which patient goes for operation and all that, and the monitoring protocol. But please try to remember the different types of hemorrhage there is, like extradural hematoma, subdural hematoma, and also subarachnoid hematomas or bleed, and also intraparenchymal bleed. So this volume of needing operational, I'm not going to ask in MCQ. I'm not going to ask in SAQ. Not very important. So all that I've mentioned in this part, cerebral protection, all these steps are actually to prevent secondary brain insult. So if you can remember this, good. Hopefully you all can remember the slide, the positioning, sedation, anti-epileptics, temperature control, avoid hypoglycemia, and avoid electron imbalance. They have been further described below in the slides, but these are the summary of it. If you can remember this is good. So purpose of this is to prevent secondary brain insults. So whatever happens in primary brain insult, so whatever happens at the site of accident, or let's say it's a gunshot wound to the head, there is nothing much you can do to reverse it anymore. So what has happened has happened. The further treatment of these patients is to actually prevent further injury, which means secondary brain insults. So that is why our focus is more when we get patients with head injury. Any other questions?
Sorry, doctor. Secondary brain what?
Insult, injury. So I mentioned in the first slide,
Oh,
right? Primary brain injury and secondary brain injury. Okay, so from this slide, so primary brain injury is the one that occurs at the time of trauma. So let's say someone was outside, then a car hits him, then he has a fall, there's head, there's injury to the head. Let's say his fall hits a stone, then there's trauma to the brain. So that is primary brain injury. So when we get these patients brought into our ED, there's nothing much we can do about the whatever that has happened in the primary brain injury. But what we do is to focus our energy to prevent secondary brain injury. So the indirect brain injury that occurs from the physiological changes. So if there's primary brain injury, there's blood clot in the brain. So we have to go and take out the blood clot. Why? So if there's increased blood clot in the brain, that will reduce the cerebral perfusion pressure. The increased intracranial pressure goes up, the cerebral perfusion pressure comes down, then patient will end up with secondary brain injuries. So our efforts are all focused on preventing a secondary brain injury. The slide on cerebral protection is all basically to prevent secondary brain injury. Any other questions? So Monroe-Kelly doctrine is important. Try to remember the Monroe-Kelly doctrine and try to remember this Glasgow coma scale. Lowest score, as I've said, it's not zero, it's not one. Lowest score is 3. The best score you can get is 15. Any score, any patient with a score of 8 or below, they are considered comatose, meaning they are in coma. So when you seen videos or movies before, right, patient is in coma. So what does coma mean? So Glasgow coma scale of 8 and below is coma. Any questions, guys?
no, doctor. No question.
This is not an easy lecture compared to the ones before this. It's a handful. It's packed with a lot of information. So takeaway I've already mentioned: Monroe-Kelly doctrine, the science of basal skull fracture, and a few other things, including this Glasgow coma scale and the type of bleedings. No need to remember the exact nature of it. Just remember the names. That is fine for me. So the usual scenario would be an SAK scenario. Patients coming in post trauma. I will probably mention a few things about uh, what of their findings, like whether they respond to pain or whether they respond to verbal response, and ask you to score a GCS. After which, then you'll be asked to describe how would you attend and manage this patient. So we expect this part of primary survey to be answered. Just a summary, and then what are the secondary goals, which is the cerebral protection, to be answered as well.
Okay, doctor.
So how's the mini test last week? Okay, all good. Everyone did well.
It is okay.
You all had the medical one last week, right? The surgical one was the week before, right? Or medical this week?
Last Tuesday, doctor.
Yeah, surgical one was last Tuesday. Medical was this Tuesday, right?
Oh, yes, doctor, yes.
Too traumatic. Nobody can remember when was it. Yeah, I will mark the papers. I've started marking a few. Probably the marks will be out in either 1 or 2 weeks time. Okay then. Thank you.
Uh, okay, doctor, thank you. We take picture.
Okay. Okay. Thank you.
Okay, doctor, thank you.